Hello students, so continuing the section of revision of images in pediatrics. So in the first section we discussed about growth and development, nutrition, basically general pediatrics and a small section of respiratory system. Here we are going to deal with a major chunk of central nervous system, CNS, and restart. Hello students, in this section we are going to discuss some of the important images in pediatrics. In the previous section we discussed about general pediatrics, growth and development, nutrition and a small section of respiratory system. Here we are going to discuss the major chunk, that is central nervous system and cardiovascular system, your CVS and CNS. So without further ado, let's start. Firstly, we are discussing the neurology topics. In neurology, congenital neural malformation is a very favorite topic as far as images are concerned. So first congenital CNS malformation that we are going to discuss is neural tube defects. Look at the image over here. Can you notice this child? So basically I am talking about neural tube defects. We know that neural tube forms a brain on one end and spinal cord on the other end. If there is failure of closure of the neuropore, either the posterior neuropore or the anterior neuropore, that leads to your neural tube defects. So firstly, we are going to discuss posterior neuropore defect. Can you notice this child? This child has a lump coming out of the back. So this is definitely a caudal neuropore defect or a posterior neuropore defect. We can have these in two forms. Look at the first form. Here I can notice that the spinal cord is intact, meninges are intact. There's just some defect in the vertebra, and overlying that defect is a tuft of hair. This defect is hidden by this tuft of hair. That's why it is known as spina bifida occulta. On the other hand, let's look at these two types, B and C. In both B and C, I can appreciate a lump coming out of the back. In B, I can see only the meninges are protruding out and it is filled with CSF. So this is known as meningocele. And on the other hand, in C, along with the meninges, now the spinal nerves, the myelin is also migrated. So this is meningomyelocele, right? In both of these forms, I can see a cyst-like structure coming out of the back. That's why collectively we label them as spina bifida cystica. Spina bifida cystica, right? Now let's look at the real-time images, what you are going to see in the clinics. In the first image, can you notice? I can see a tuft of hair coming out. This is nothing but spina bifida occulta. On the other hand, look at this. A cyst-like structure coming at the back. This is spina bifida cystica. It can be a meningocele, it can be a meningomyelocele. You cannot tell that with the naked eye. You have to go for imaging, either ultrasound or MRI, to know the contents of this cyst. Then only I can tell whether this is a meningocele or a meningomyelocele. Right? With that, now let's move anteriorly to the anterior neural tube defects. I have the first malformation where I see the cystic structure coming out of the back of the head of this child. This is encephalocele. Encephalocele. And on the other hand, look at this child, child P. There's some occipital bone defect, cervical spine defect, and because of that occipital bone and cervical spine defect, the child has an hyperextended posture, star-gazing posture. Right? This is nothing but anencephaly. In anencephaly, you see the star gazing. You see the star gazing posture. Along with that, there is occipital bone defect and cervical spine defect. This is anencephaly. Right? So with that, we are done with the neural tube defects, both caudal as well as cranial neural tube defects. Now let's move to some malformations of the brain parenchyma. Firstly, we are discussing about posterior fossa malformations. In this, you need to know two major malformations, Dandy-Walker and Arnold-Chiari. Look at this first image. Can we notice the posterior fossa here is empty? This is nothing but Dandy-Walker malformation. What happens in Dandy-Walker malformation? There is defective roof of the fourth ventricle leading to this hollowness in the posterior fossa. So this is nothing but Dandy-Walker. So in normal, you can see that the posterior fossa is filled up like this. If it is empty, this is nothing but Dandy-Walker malformation, defective roof of the fourth ventricle. Then we have next posterior fossa malformation. Look at here. There is herniation of the cerebellum, uncal herniation. On the other hand, look at the second image, image B. It looks like as if the entire brain parenchyma is sliding down. This is Arnold-Chiari type 2. So both are Arnold-Chiari. In type 1, you see that there is just uncal herniation, Arnold-Chiari type 1. And in Arnold-Chiari type 2, you see that the entire brain parenchyma as if it is sliding down. Right? So this completes our posterior fossa malformation. Remember Dandy-Walker as well as Arnold-Chiari malformation. Then we come to this important image. Can you notice here? There's some dilatation of some vein happening. What is that vein? This is nothing but vein of Galen malformation. Vein of Galen malformation. Why this is happening? Because there is a persistent embryonic vein, persistent median prosencephalic vein, and because it is a primitive structure, it undergoes aneurysm formation, dilatation, and because of that, it can obstruct the CSF flow pathway leading to hydrocephalus. So very important image, vein of Galen malformation. Then let's move on to some parenchymal issues. Normally, we all know our brain parenchyma has some gyri, sulci. The surface of our brain is not smooth. It's convoluted, right? We have gyri, sulci. But here, the surface appears to be very smooth. This is absence of gyri, agyria. This is known as lissencephaly. On the other hand, look at the second image. It looks like as if there is a cleft in the brain. There is a split that is dividing the brain into two halves. This is schizencephaly. Right, schizencephaly. Now let's see the next image. It looks like as if there is a hole, there is a pore in the brain parenchyma. This is known as parenchymal. Right? It feels like as if someone has punched a hole, made a pore, parenchymal. In the second image, what can you see? I can see that there is a connectivity between the two ventricles on both the sides. This is when the corpus callosum is absent. In cases of corpus callosum agenesis, you see these separate connections of the ventricle. Right? This is nothing but corpus callosum agenesis. And this particular sign, because of this connection, is known as racing car sign. So you see a racing car sign in cases of corpus callosum agenesis. Now with that comes a very important syndrome. Look at this image. What can you see? Here I can see that in the retina there are certain holes. Right? There are holes, lacunae in the retina. These are chorioretinal lacunae. Why I am discussing this chorioretinal lacunae in the neurology section? Because remember, this chorioretinal lacunae along with corpus callosum agenesis, racing car sign that we just read, along with infantile spasm, these are seen in a syndrome known as Aicardi syndrome. Right? So now let's move to an important topic, hydrocephalus. Can you notice the size of the head of this baby? The size of the head of this baby is huge. It's macrocephaly. And when I light up a torch against the head, it brights up like this. What is this known as? This is known as transillumination positivity. And look at the eyes of this child looking down. This is known as sunset sign. And if I percuss over the skull of this child, I'm going to hear a crackpot resonance. Crackpot resonance. All of this you are going to see in hydrocephalus, where the increase in the amount of CSF is there. There is hydrocephalus, right? To relieve that hydrocephalus, we have medical management as well as surgical management. In surgical management, it's very important that you know about these shunts: ventriculoperitoneal shunt and ventriculoarterial shunt. What I am doing in shunt, I am placing a tube to divert this excess CSF from my brain to somewhere else in the body so that it can be cleared out. In VP shunt, that is ventriculoperitoneal shunt, I place one end of the shunt into the ventricles and the other end into the peritoneum. Right? This is nothing but VP shunt or ventriculoperitoneal shunt. Ventriculoperitoneal shunt. On the other hand, look at the second image. One end of the shunt is in the ventricles and the other is in the artery connecting the heart. This is known as VA shunt, that is ventriculoarterial shunt. Ventriculoarterial shunt. Right? Now let's move to yet another important entity, cerebral palsy. I have 3 children in front of me. Look at the first child, where one half of the body is affected. Look at the other child, only the lower limbs are affected. And the third child, where all the 4 limbs are affected. When half of the body is affected, this is hemiplegic cerebral palsy. When the lower limbs are affected, this is known as diplegic cerebral palsy. And when all the 4 limbs are affected, this is quadriplegic cerebral palsy. Now let's learn in what all these conditions do we appreciate such a scenario. Firstly, half of the body, hemiplegic cerebral palsy. It is usually seen in cases of stroke, particularly perinatal strokes. Because of affection of one side of the body, you will see a typical circumduction gait. This child can also have early handedness, that is one preference of the hand towards one side, right? In diplegic sleepy, usually the candidates are the preterm babies with injuries like intraventricular hemorrhage or periventricular leukomalacia. On the other hand, in quadriplegic sleepy, it is usually a term child with hypoxic ischemic encephalopathy, hypoxic injury to the brain leading to quadriplegic CP. Though we are discussing the brain injuries over here, I want to discuss a very important brain injury that can happen in neonates, that is kernicterus. What is kernicterus? When there are very excessive levels of bilirubin in a child, in a newborn, it can cross the blood-brain barrier and damage the basal ganglia. And because of the damage of the basal ganglia, you're going to see extrapyramidal symptoms. This is known as dyskinetic CP, dyskinetic cerebral palsy. Right? Now coming down to infections of the CNS, a very important sign that we see in meningitis. Look at the sign A. I am just flexing the neck of the child, and in response to that, the child is lifting up his legs like this. What is this sign? This is Brudinsky sign. Brudinsky sign. On the other hand, look at B. What I am doing in B, I am just extending my knee over the flexed thigh. And while doing so, there is some resistance, and the child might lift up the head also. What is this known as? This is Kernic's sign. Kernic's sign. So remember, when you are lifting the knee, K for knee, you see Kernic's sign. And when you are lifting the head, this is Brudinsky sign. With that, now let's just look at some of the MRI imaging of meningitis. So look at the first image. Can you notice the brightness in the basal region? These are nothing but basilar exudates. These basilar exudates are typical in cases of TB meningitis, tubercular meningitis. And if I take the CSF sample of this child and let it stand for some time, you're going to appreciate this. Formation of a web-like structure. This is known as cobweb appearance. cobweb appearance. Right? Very typical of tubercular meningitis. Now let's move on to the next picture. Here in this meningitis, the basal ganglia, the thalamus are affected. This is nothing but typical of Japanese encephalitis. Japanese encephalitis. Right? And when you see the affection of temporal regions, needless to say, it is nothing but herpes simplex virus, HSV encephalitis. Right? With that, now let's move down to the neuromuscular disorders. Look at this baby. One half of the face is involved. There is weakness on the one side of the face. And as the day progresses, this weakness worsens. And when I give this one injection, I can appreciate that this weakness resolves on its own. What's this? This is a neuromuscular disorder known as myasthenia gravis. Myasthenia gravis. Right? This myasthenia gravis, we all know there are some antibodies formed against the receptors, and because of that, as the day progresses and more receptors are being occupied, I see progressive weakness. So whenever you see a progressive weakness, think of neuromuscular disorders. As the day progresses, this weakness will increase. By giving injections like edrophonium, what we are doing, we are just increasing the acetylcholine levels in that synaptic region, and because of that, I see an improvement. This is the typical picture that they ask in the exam. On EMG, that is electromyography, whenever you give stimulation to the nerve, you see a muscle contraction. Each and every time you should have a similar response. But if you see a detrimental response, that is characteristic of your neuromuscular disorders like myasthenia gravis. Now let's look at this picture. Again, muscle problem. What is the muscle problem over here? I am just asking this child to sit up while he is lying down on the floor. And while I ask him to do so, how is he standing up? He is just climbing on himself. This is known as Gover's sign. Gover's sign. And where do you see this Gover's sign? Whenever there is some proximal muscle weakness. In cases of proximal muscle weakness, you see this Gover's sign. And typical example that we encounter is DMD, Duchenne muscular dystrophy. Another feature that you see over here is this calf hypertrophy. Looks like the calf muscles are very well built, but it is not hypertrophy. This is pseudo hypertrophy, right? This is calf muscle pseudo hypertrophy. The muscle has not hypertrophied. It is just the deposition of fiber and fat. So there is just fibrofatty deposition. Right? Now let's see this. I'm asking the child to just push against the wall, and I see this winging of scapula. Can you notice the winging of the scapula? Where do you see this? We see this in scapulohumeral dystrophies. Right? So because of that, there is this winging of scapula, and also if you try to make this child flex his biceps, you will appreciate that the forearm is quite heavy and the upper arm is not that heavy. This is classical Popeye arm appearance, again seen because the humeral muscles, they are very weak, right? So this is all about our neurology section. Now let's move to the cardiology segment. So in cardiology, important is your chest x-rays. More or less, you are going to get a chest x-ray or just the name of the appearance that we appreciate on the chest x-ray. And they will ask you to identify which type of congenital heart disease is there. So with that, let's see the first x-ray. What can you notice over here? Look at these red arrows. They are pointing towards the rib. If you notice, if this is a rib, you see a notch over here. Can you notice the notch? Right? There is some notch over here. This is known as inferior rib notching. Inferior rib notching. And also I see this sign. What is this sign? This is known as 3 sign. Again typical. 2 typical findings, inferior rib notching and 3 sign. This we see in coarctation of aorta. Coarctation of aorta. We all know what is coarctation of aorta. There is some narrowing in a segment of descending aorta. Depending upon whether how much narrowing is there, symptoms are going to vary. If the narrowing is quite severe, then this child will present in the neonatal age itself with symptoms of shock. On the other hand, if there is partial narrowing, there will be some problems happening in the future. As we all know, descending aorta is important to supply the lower limbs, supply the adrenals, supply the kidneys. So there will be hypertension issue, there will be intermittent claudication. All of those factors you are going to appreciate later on in life. Now let's move to the second X-ray. A characteristic X-ray. Look at the shape of the heart. It is not looking normal, right? What is the shape over here? This is known as boot-shaped heart. Boot-shaped heart. And where do we appreciate this boot-shaped heart? This boot-shaped heart we appreciate in tetralogy of Fallot, which is the most common cyanotic congenital heart disease that we encounter in pediatric population. So this tetralogy, the name itself has tetralogy, so it has four things. Firstly, there is right ventricular hypertrophy, there is pulmonary stenosis, there is ventricular septal defect and overriding aorta. What is problematic over here? TET spells. That in cases of stress, there will be bluishness, TET spells because there is infundibular spasm worsening the cyanosis in this child. And the treatment here, immediate, would be to do squatting or knee chest position. Thereafter, we can use drugs like beta blockers, alpha agonist, and definitive treatment is making shunt, Belloc Taussig shunt, where we connect our pulmonary circulation to the systemic circulation. We connect the pulmonary artery to our subclavian arteries. This is the Belloc Taussig shunt. We have discussed more in detail about these in the main videos. If you wish to know more and more about these treatments, please refer to those videos. This is revision, so that's why I'm just brushing up. Remember the name of the shunt, Belloc Taussig shunt. Apart from that, we have Watterson shunt also, Pott shunt also, but Belloc Taussig shunt is something which is very important for your exam. Now let's move to the next image. What is the shape of this heart? I have made an animated image side by side also. This looks like a box-shaped heart. Where do you see this box-shaped heart? This box-shaped heart is seen in an anomaly that is known as Epstein anomaly. What happens in Epstein anomaly? There is displacement of my tricuspid valve down. So there is atrialization of ventricles. And because the atria have taken more and more space down there, the ventricles receive very less blood, leading to cyanosis, right? So there is box-shaped anomaly. It is commonly associated with mothers who are on lithium for their bipolar disorder. So if mother is taking lithium, then the child can have these Epstein anomaly, increased predisposition to develop such an anomaly. Let's move to the next image. Again, compare with the animation. This is egg on string appearance. Egg on string appearance. Where do you see this egg on string appearance? We see this in transposition of great arteries. Transposition of great arteries. Then the next image, figure of 8 appearance. Looks like an 8, right? Figure of 8 appearance or snowman appearance. This figure of 8 or snowman. Where do we see this? We see this in TAPVC. Which type of TAPVC? Supracardiac TAPVC. Total anomalous pulmonary venous connection. Right? So let's recap all the images that we have discussed. First, inferior rib notching and 3 sign. This is nothing but coarctation of aorta. Then we say boot-shaped heart. This we see in tetralogy of Fallot. Then we have box-shaped heart. We see in Epstein anomaly. And lastly, egg on string appearance, transposition of great arteries. So with that, we complete the section of images on cardiovascular system and central nervous system. I hope you are getting the just how important the x-rays are. In a span of last 10 to 15 minutes, I have revised multiple times these examples. It can come in the match in the following format. It can come as a one-liner. It can come as an image-based question. Very high yield, right? So remember, congenital heart disease and their corresponding x-rays are something that you cannot afford to miss, right? So with that, we cover the images in the pediatrics. Thank you.